For USMLE Step 1. The topic of today's lecture is neoplasia. In considering neoplasia, one must begin by considering cancer epidemiology. Note that both for males and females, there is a difference between cancer incidence and cancer mortality. In terms of incidence, in males, prostate leads the pack, followed by lung and then colorectal cancer. However, in terms of mortality, lung is by far and away far more lethal, followed by prostate and colorectal cancer. In women, breast leads in terms of cancer incidence, followed by lung, most likely due to an increased number of women smoking, and then colorectal cancer. Again, however, in terms of mortality, lung leads the pack, followed by breast and then colorectal cancer. In terms of the basics, when one considers neoplasia, first of all, remember that neoplasia simply refers to new growth, but it is new growth that we consider to be not reversible. This is in contrast to dysplasia, which is disordered growth, which is often, not always, but often reversible, but which the end result of dysplasia, if left unchecked, can be neoplasia. Tumor is a general term referring to a mass which can be either benign or malignant, but the term cancer itself refers specifically to a malignant neoplasm. It is worthwhile to stop for a moment and go over some etiology when we are talking about the naming of tumors. If we're dealing with tumors that arise from epithelium, when we're referring to benign tumors, we'll refer to them by names such as adenoma or papilloma. If they become malignant, we replace the oma at the end of the benign name with carcinoma. So an adenoma's malignant version is an adenocarcinoma, and the malignant version of a papilloma is, not surprisingly, a papillary carcinoma. Tumors of the mesenchyme, these will generally be things like fibromas or lipomas, if you remember from the soft tissue lecture, and the malignant versions of these will be sarcomas, hence the osteosarcoma, fibrosarcoma, chondrosarcoma, etc. For melanocytes, the benign tumor is a nevus, and of course the malignant tumor here is the melanoma. Lymphocytes in general are not considered to have a benign tumor of any type. Instead, there's only a malignant form, which is named, not surprisingly, a lymphoma. There are certain characteristics of a tumor which will lead you to believing that it is benign clinically, even without knowing anything about the histology or genetics of the tumor. Benign neoplasms tend to be small size, they are slow growing, and when looked at grossly, they will be well encapsulated or have sharply demarcated borders. They also will be well differentiated, that is, you may have a hard time telling where the benign tumor begins and ends and normal tissue begins. What is shown here in this example is simply an example of a follicular adenoma of the thyroid whose tissue closely resembles the normal follicles of the normal thyroid gland. Malignant neoplasms, on the other hand, tend to have different characteristics. They will be large and demonstrate rapid growth. When looked at grossly or microscopically, they will have areas of necrosis and hemorrhage, and also they will be poorly demarcated. One may have a difficult time determining where the cancer ends and normal tissue begins. Cells, when looked at individually, will be what we term pleomorphic. There will be variations in cell size and shape. You will see an increased nuclear to cytoplasmic ratio. In most cells, the nucleus generally should occupy less than a third of the cell. In malignant cells, the nuclei can often come to occupy almost the entirety of the cell, pushing a thin rim of cytoplasm to the edge of the cell. The nuclei will be hyperchromatic and have prominent nucleoli, and there will often be a high mitotic rate with abnormal mitotic figures present. Note some of these features present here in the slide to the right of this slide. You see the presence of an adenocarcinoma up top. Note the disordered proliferation of glands. On the bottom, note the tumor cells here, the malignant cells that have some of the features we described on the left, the high nuclear cytoplasmic ratios, the atypical nuclei, and note the presence of an atypical mitosis present in the middle of the slide. Malignant neoplasms are also characterized by their behavior. They have the ability to invade and metastasize. Often the ability to metastasize may be the only feature one has that determines that a tumor is actually malignant. They also will metastasize not only to distant locations, but will infiltrate adjacent tissues or vessels. Remember, carcinomas tend to prefer to move around the body by lymphatics, while sarcomas would enjoy moving around the body using the blood vessels. Lymph node involvement will generally follow the natural lymph node drainage that surrounds an organ system. Hence, for example, testicular tumors like to go to the para-aortic and iliac nodes. Now for the general process of carcinogenesis. Fundamentals that one needs to remember is that before one actually has the development of the tumor, one often needs several successive steps of non-lethal genetic damage. There are 4 classes of regulatory genes that we're going to be concerned with when we talk about carcinogenesis. These are growth-promoting genes, or proto-oncogenes or oncogenes, growth-inhibiting tumor suppressor genes, genes that are important in the regulation of apoptosis, and genes that are involved in DNA repair. We will talk as we go along today about examples for each. Remember that carcinogenesis is often a multi-step process. You need to have several successive genetic hits for a tumor to actually develop. And then remember that tumors tend to arise from clonal expansion of a single genetically damaged precursor cell. This cartoon we will refer to several times in the course of this lecture, as it simply outlines the multi-step process needed for the development of a tumor. Note that all cells, all normal cells, generally fluctuate between being normal and having to repair DNA damage. You have the beginning of the development of cancer when, for some reason, this repair process gets skewed towards the inability to repair DNA damage. This leads to mutations in the genome of somatic cells. You then have other steps in the process, such as the activation of growth-promoting oncogenes, inactivation of tumor suppressor genes, or alterations in genes that affect cell apoptosis. This combination of unregulated cell growth, along with decreased apoptosis, leads to the clonal expansion of a genetically damaged cell, and it is this cell that leads to the eventual development of a tumor that becomes a malignant neoplasm that can go on to invade and metastasize. Now, there are various environmental factors that can lead to the development of these sort of somatic changes that lead to the development of a tumor. Many of these are chemicals in our environment, and how we determine that they're carcinogenic is by the use of what's called the Ames test. This is a simple screening test to try and determine if chemicals are carcinogenic. It determines the mutagenic effects on bacterial cells in culture, but it does have a major underlying assumption, and that is that this mutagenicity in vitro correlates with carcinogenicity in vivo. Some of the different compounds and chemicals that we have determined to be carcinogenic over time have been things such as nitrosamines that you might find within cured meats. These appear to play a role in the development of gastric adenocarcinoma. Perhaps one of the most famous carcinogenic chemicals is asbestos, which has been shown to play a role in lung cancer and mesothelioma. Chromium and nickel are also involved in the development of lung carcinoma, and arsenic, which can be found in the soil or sometimes in our water, is associated with squamous cell cancer of the skin and lung, and also with angiosarcoma of the liver. Vinyl chloride is associated also with angiosarcoma of the liver, and various alkylating agents that one may use to treat other cancers as a form of chemotherapy can lead to the development of secondary tumors, particularly leukemias and lymphomas. Those people who are exposed to large amounts of naphthalene have been shown to have an increased risk of bladder cancer. There are other elements within our environment that also can damage our DNA, mutate genes, and lead to the development of cancer. One of the most common of these is radiation. Ultraviolet radiation produces pyrimidine dimers in DNA that leads to transcriptional errors and mutations of both oncogenes and tumor suppressor genes. There is a nucleotide excision repair pathway which is supposed to try and keep these mutations in check. However, in patients with disorders such as xeroderma pigmentosum, there is essentially a knockout of this repair process. They are defects in DNA repair, and thus these patients develop numerous tumors, including squamous cell carcinomas, basal cell carcinomas, and malignant melanomas after exposure to ultraviolet radiation. Ionizing radiation can also lead to the development of DNA damage. This is often seen in people who have been exposed to the effects of atomic bombs or have had effects such as those seen in people around the Chernobyl disaster. X-rays, gamma rays, alpha and beta particles, protons and neutrons can all affect DNA. One again sees this effect with survivors of the atomic bomb who had a higher incidence of leukemias and thyroid cancers. Uranium miners had an increased rate of the development of lung cancer. People who are treated with radiation for other tumors, such as those people who receive radiation for squamous cell cancers of the head and neck, are prone to the development of secondary tumors, particularly thyroid cancer. Those people who mined and made the radium dials that were used in the early stages of wristwatches that could be viewed at night had a predilection for the development of osteosarcoma. And radiologists, particularly before we understood what were the safe limiting exposures levels for radiation, had an increased development of skin cancer and myeloid leukemias. There are also infectious agents within our environment that can act as oncogenic agents. The most famous of these, perhaps, in this day and age is human papillomavirus. Types 16, 18, 31, 33, and 45 can predispose women to the development of cervical cancer, can also predispose both men and women to the development of possible laryngeal cancers, and in men the development of squamous cell cancer of the penis. Epstein-Barr virus likes to infect B cells and epithelial cells of the nasopharynx. It can lead to the development of various tumors, including Burkitt's lymphoma, B-cell lymphomas in immunocompromised patients, Hodgkin's disease, and nasopharyngeal carcinomas. Hepatitis B is involved in the development of hepatocellular carcinoma, as is hepatitis C. Human T-cell leukemia virus type 1 infects CD4 positive T cells and can produce T-cell leukemias and lymphomas. The bacteria are not to be left out here. Helicobacter pylori, one of the common causes of gastritis, has been linked to the development of gastric cancers and B-cell lymphomas. Interestingly enough, simply by treating the infection and eradicating the Helicobacter pylori, one can often get at least the lymphomas here to reverse. Now, we've listed some of the ways in which DNA damage can occur. Failures of DNA repair are also involved in the development of the DNA damage that predisposes people to the development of cancer. Remember that your cells are constantly synthesizing and replicating their DNA. It is impossible for 3 billion pairs of base pairs of DNA to be replicated without mistakes being introduced, even without the effects of environmental agents, viruses, and bacteria. Thus, mistakes in DNA replication have to be repaired, and this is done by, naturally enough, DNA repair genes. Defects in DNA repair, however, can be detected, often with instability in what are termed microsatellites. Microsatellites are tandem repeats of 1 to 6 nucleotides scattered throughout the genome. The number of repeats that one should have should be fixed for life, and if one finds a change, particularly in the transmission of these microsatellite repeats from one generation to another, that is a sign that there is some difficulty in DNA repair. Mutations in one of two genes, MSH1 and MLH1, account for over 60% of cases of hereditary non-polyposis cancer syndromes, and this will be reviewed further in the GI lecture. Another example of defects in DNA repair genes has been mentioned earlier in defects that lead to xeroderma pigmentosum. Now we come to the complex balance that must be maintained between the activation of growth-promoting oncogenes, inactivation of tumor repair genes, and alterations of genes that control apoptosis. These represent some of the classes of genes that have to be damaged for a cell to become carcinogenic, clonally expand, and lead to the development of a malignant tumor. There are again 4 classes of genes that are generally damaged and lead to the development of a tumor. These include the growth-promoting oncogenes, growth-inhibiting tumor suppressor genes, genes that regulate apoptosis, and genes involved in DNA repair. Now, to deal first with those genes that control cell growth, these are the proto-oncogenes. These are normal cellular genes that are normally involved in promoting cell growth and differentiation. Oncogenes are derived from proto-oncogenes, but their important point is, unlike the proto-oncogenes, oncogenes are not regulated. This leads to unregulated cell proliferation and growth. Now, to deal first with those genes that control cell growth, these are the proto-oncogenes. These are normal cellular genes that are normally involved in promoting cell growth and differentiation. Oncogenes are derived from proto-oncogenes, but their important point is, unlike the proto-oncogenes, oncogenes are not regulated. This leads to unregulated cell proliferation and growth. How does one go from a proto-oncogene to an oncogene? Well, there are things that can be involved, such as point mutations that are involved in the RAS gene, chromosomal translocations, such as the 814 translocation that is involved in the development of Burkitt's lymphoma, and also gene amplification, such as what one sees with the amplification of NMYC in neuroblastoma. Various genes that can serve as oncogenes include growth factors, such as HST1 or INT2, both of which interact with fibroblast growth factor, the former being involved with the development of stomach cancer, the latter with tumors of the stomach, breast, bladder, and also in melanoma. The growth factor SIS is involved in the development of a tumor of the brain, astrocytoma. Growth factor receptors can also be involved. This includes things such as the epidermal growth factor receptor, which is involved with numerous tumors, including squamous cell lung cancer, astrocytomas, and breast cancer. HER2/neu is overexpressed in breast and ovarian cancers and generally leads to a poor prognosis for these patients. And the RET factor is involved in the development of multiple endocrine neoplasia types 2 and 3. Other signal transducers can also serve as oncogenes. This includes the ABL gene, which is involved in the BCR-ABL chromosomal translocation seen in some forms of leukemia. The tumors that this can be seen with are chronic myelogenous leukemia and also acute lymphoblastoid leukemia. The KRAS oncogene is involved in tumors such as lung, pancreas, and colon. Various nuclear regulators can also serve as oncogenes. This includes NMYC, which we previously mentioned, being involved in neuroblastoma, also CMYC and LMYC, the former CMYC involved in Burkitt's lymphoma, and LMYC being involved in small cell carcinoma. Also, cells that regulate the cell's entry and exit from the cell cycle can also serve as oncogenes. This includes genes such as cyclin D1, which is seen in the development of mantle cell lymphoma. Let's focus for a moment more closely on cyclin D1. Cyclin D1's role is to bind and activate CDK4 during the G1 phase of the cell cycle. This complex of cyclin D1 and CDK4 phosphorylates the retinoblastoma protein, which frees retinoblastoma from E2F. The hypophosphorylated form of retinoblastoma is bound to E2F and recruits histone deacetylase, which causes compaction of chromatin and inhibits transcription. The freed form of E2F initiates transcription of cyclin E, allowing progression of the cell into the S phase. This is demonstrated in the cartoon to the right of this slide. Note that there are various other factors involved which will try and keep the cell from entering into the cell cycle. This includes molecules such as P53, which acts through P21, also P16INK4, and P27. To focus more closely on the oncogene RAS, it is part of the G proteins, which are membrane signaling proteins that mediate signal transduction. This is activated by GTP binding when deactivated by inherent GTPases, which is augmented by GPase augmenting proteins. Mutated RAS, which again is seen in things such as colon cancer, binds GAP, but GTPase activity fails to be augmented. Activated RAS turns on the pathway called MAP kinase, and this GTPase activity is lost in cells that have a mutated RAS. RAS is important because it's found to be mutated in over a quarter of all cancers. This cartoon simply demonstrates the normal form of RAS and how it is expected to interact with GTP and from the creation of GDP and the activation of the MAP kinase pathway, which then translocates signals to the nucleus and leads to the activation of transcription and cell cycle progression. This covers the activation of growth-promoting oncogenes, which is one of the steps that leads to the development of cancers. We're now going to move in this next section to the inactivation of tumor suppressor genes. This ends the first part of this Falcon Pathology Review Series for USMLE Step 1 on Neoplasia.